Bipolar disorder is not just being emotional, and it is not the same as ordinary mood swings. It is a brain-based mood disorder in which a person has episodes of mania or hypomania on one side and depression on the other, often with major changes in energy, activity, sleep, concentration, and behavior. The key word is episodes. These states are not just passing reactions to a bad day or a good day. They are sustained changes in mood and brain function that can interfere with work, judgment, relationships, and sometimes reality testing itself. Bipolar disorder often starts in late adolescence or early adulthood, can be misdiagnosed for years, and usually requires long-term treatment. The easiest way to understand bipolar disorder clinically is to picture it as a disorder of mood state regulation. In bipolar 1, the person has had at least one manic episode, and that mania can be severe enough to require hospital care. In bipolar 2, the person has depressive episodes plus hypomanic episodes, which are similar to mania but less severe and less functionally destructive. There are also mixed episodes, where depressive and manic symptoms happen together, and rapid cycling, which means 4 or more major mood episodes in a year. What makes this condition so serious is that mania is not just feeling great, and depression is not just feeling sad. Mania can bring racing thoughts, decreased need for sleep, inflated confidence, impulsive spending, risky behavior, irritability, and sometimes psychosis. Depression can bring slowed thinking, hopelessness, inability to function, loss of interest, and suicidal thinking. Now for the neuroscience. The short version is that bipolar disorder seems to involve instability in the brain systems that regulate reward, emotion, attention, and biological rhythms. One major theory focuses on dopamine. Dopamine is not just a pleasure chemical. It helps regulate motivation, salience, reward prediction, drive, and goal-directed behavior. A major review in molecular psychiatry describes converging evidence that mania is associated with a hyperdopaminergic state, meaning reward and drive systems may be running too hot. That fits the clinical picture of mania very well. Everything feels more meaningful, more urgent, more exciting, and more possible. The same review also describes the long-standing hypothesis that depressive phases may involve relative hypodopaminergia, meaning to little drive and reward signaling, which fits the slowed, heavy, low motivation state of bipolar depression. The important nuance is that bipolar disorder is probably not just too much dopamine or too little dopamine. It is more likely a disorder of dysregulation where the systems that are supposed to stabilize mood states do not hold steady enough. That dopamine story connects directly to brain circuits. Modern neuroimaging models describe abnormal function in a ventral affective and reward network that includes areas like the orbitofrontal cortex, ventral striatum, nucleus accumbens, thalamus, amygdala, hippocampus, and several parts of the prefrontal cortex. The ventral system is strongly involved in reward, emotional salience, and autonomic emotional response. The dorsal cognitive system, including regions like the dorsolateral prefrontal cortex, is more involved in planning, working memory, selective attention, and explicit regulation of emotion. Reviews in translational psychiatry describe bipolar disorder as involving an overactive emotional ventral system and a relatively underactive dorsal regulatory system. In plain English, the emotional accelerator may become too strong while the braking and steering systems become too weak. That is one reason mania can feel fast, powerful, and poorly restrained. While even outside full episodes, many people with bipolar disorder can still struggle with impulse control, emotional regulation, or cognitive consistency. One especially important relationship is between the prefrontal cortex and the amygdala. The amygdala helps process emotional salience, especially threat, intensity, and emotional significance. The prefrontal cortex helps regulate those responses, place them into context, and decide what deserves action. In bipolar disorder, research reviews describe decreased activity in parts of the ventrolateral prefrontal cortex and increased activity in the amygdala, striatal regions, and medial prefrontal regions during emotional processing tasks. That matters because it gives a plausible brain-level explanation for why emotions in bipolar disorder can feel so amplified, immediate, and hard to govern. During mania, this can help produce grandiosity, irritability, explosive energy, and emotional overconfidence. During depression, the same unstable circuitry may contribute to emotional pain, negative bias, and difficulty regulating stress. Another major piece is circadian rhythm dysfunction. This is one of the most important and underrated parts of bipolar neuroscience. Bipolar disorder is strongly linked to disturbed sleep and disrupted biological rhythms. And reviews have described circadian dysfunction as a prominent feature of the illness. That matters because sleep and circadian timing are not just background wellness habits. They are core timing systems for hormone release, alertness, mood regulation, reward sensitivity, and brain energy use. In bipolar disorder, sleep loss is not just a consequence of mania. It can also be a trigger. A person may start sleeping less, and instead of becoming simply tired, their brain shifts into a more activated state that can escalate into hypomania or mania. This is one reason why social rhythm therapy exists and why routine, light exposure, sleep timing, and behavioral regularity matter so much in treatment. In bipolar disorder, the clock system and the mood system appear deeply entangled. Genetics also matter, but not in a simple one-gene way. NIMH notes that bipolar disorder often runs in families and is mostly explained by heredity. But that many genes are involved and no one gene causes the disorder by itself. Identical twin studies also show that genes are not the whole story. Because one twin can develop bipolar disorder while the other does not, that points to a multifactor picture where genetic vulnerability interacts with life stress, sleep disruption, developmental factors, and possibly substances or other psychiatric conditions. NIMH also notes that brain structure and function can differ in people with bipolar disorder, although those differences are not currently used as a simple diagnostic test. So the modern scientific view is not that bipolar disorder comes from one broken molecule or one damaged brain region. It is more like a disorder of network instability in a genetically vulnerable brain. So what does bipolar disorder actually feel like from the inside? Mania can feel amazing at first, which is part of what makes the illness dangerous. A person may feel unusually powerful, creative, confident, fast, charming, productive, or unstoppable. Sleep starts to seem unnecessary, thoughts become quicker, speech becomes more pressured, ideas connect rapidly, risk stops feeling risky. But as mania intensifies, the state can become chaotic, irritable, aggressive, grandiose, and detached from consequences. Judgment erodes, spending can explode, relationships can be damaged, psychosis can appear. Bipolar depression feels different from ordinary sadness too. Many people describe it as leaden, slowed, mentally painful, and biologically crushing, with motivation collapsing and even simple tasks feeling impossibly difficult. Mixed states are often among the most dangerous because they can combine depressive despair with manic agitation and energy. Treatment makes more sense once you understand the neuroscience, because mania is closely tied to overactivation of dopamine-linked and reward-linked circuits. Antipsychotic medications are commonly used to bring those states down. Because bipolar disorder is recurrent, mood stabilizers are central long-term tools, and lithium remains one of the most important examples. NIMH and NHS sources describe lithium as a mood stabilizer used in bipolar disorder, and psychotherapy is also an important part of care, especially approaches like interpersonal and social rhythm therapy that work with biological and social routines. Another crucial point from NIMH is that if bipolar disorder is mistaken for unipolar depression and treated with antidepressants alone, mania or rapid cycling can sometimes be triggered. That is one reason accurate diagnosis matters so much. So if you want the deepest summary, here it is. Bipolar disorder is a disorder of brain state regulation. It affects the systems that control reward, motivation, emotional salience, cognitive control, and circadian timing. In mania, the brain may enter a state of excessive activation, especially in reward and emotion circuits, while the systems that normally regulate impulse and emotional intensity fail to contain that surge. In depression, the same overall network becomes underpowered, slowed, and unable to generate drive, pleasure, and emotional stability. It is not simply a personality trait, not a lack of discipline, and not a person choosing to be extreme. It is a serious neuropsychiatric condition in which the machinery that keeps mood stable becomes unstable, and when that machinery shifts, it can change energy, thinking, sleep, judgment, and the entire way a person experiences being alive.